The precision pulse capsulotomy procedure, or PPC as it is commonly referred to, is a novel non-laser automated capsulotomy procedure as an alternative to femtosecond laser capsulotomy. The procedure received its CE mark in 2015 and US FDA approval in 2017. The instrumentation comprises a console connected to a disposable handpiece called Zepto that is introduced into the anterior chamber for the capsulotomy. The Zepto consists of a soft, transparent silicone suction cup 6 millimeters in diameter. This suction cup houses a circular ring made of nitinol, that is nickel titanium alloy. How does a 6 millimeter suction cup get through a 2.2 millimeter corneal incision? Nitinol has the property of shape memory, so it can be easily elongated with the help of a retractable metal push rod to fit easily into the anterior chamber, and upon retracting the push rod, the compressed tip resumes its native circular shape within the anterior chamber. The suction cup is centered and positioned over the anterior capsule. Suction is applied with the help of the external console. Incidentally, this suction is very much unlike that which is used in refractive procedures. Only a very slight amount of suction is required to oppose the nitinol ring to the anterior capsule. These electrical impulses result in phase transition of water molecules trapped between the capsule and nitinol edge, resulting in a volume expansion that causes mechanical cleavage of the stretched capsular membrane. The important characteristic of this technology is that the capsulotomy results in an instantaneous, simultaneous cleavage of 360 degrees of capsule without cauterization of tissue. The excised capsular button can be removed from the underside of the suction cup after removal from the eye. The capsulotomy has a diameter of about 5.2 millimeters, but now handpieces with bigger size rings are also available. A zeptosecond is 1/1,000,000th of a femtosecond. The small size of the instrument and the ultra short time required for it to function inspired its name. Now let's look at some of the advantages of the Zepto PPC. This is mainly in comparison to femtolaser assisted capsulotomy. Seamless incorporation into the normal operating sequence without the workflow, personnel challenges, and increased procedural time of flax. Reduce procedural costs compared to femto and so more affordable to a greater number of people. Unlike femtocapsulotomy, the cortex is not affected and only the capsule in contact with the nitinol ring is cut. Zepto PPC permits the capsulotomy to be centered on the patient's visual axis intraoperatively by use of the Purkinje images. This technique, described by Dr. Vance Thompson, makes use of the Chang and Waring's subject-fixated, coaxially sighted corneal light reflex. The capsulotomy is well centered on the visual axis along with excellent capsular overlap, which is especially valuable in the implantation of multifocal, EDOF and toric IOLs. There is no need for trypan blue staining in white cataracts and those with a poor red reflex. The procedure can be performed when visibility of the capsule is poor, such as in corneal opacities. It can be performed after the use of iris expansion devices in small pupils, and if the pupil is at least 4 millimeters in size, the flared lip of the silicone cup can be inserted beneath the iris to expand the pupil without the need for another expansion device. In intumescent cataracts, the simultaneous 360-degree capsulotomy results in instantaneous decompression, thus avoiding the generation of radial tears. Finally, the learning curve is fast. It has also been reported to create a successful capsulotomy in pediatric cataracts in a case with 6 hours of zonular dialysis, thick and peripheral anterior subcapsular cataract, traumatic anterior capsular cataract with posterior synechiae, severe anterior capsular contraction syndrome following cataract surgery, etc. Coming to the disadvantages, radial tears and incomplete capsulotomy can occur if the suction is inadequate, such as when there are air bubbles trapped between the suction cup and clogging of the suction tip by highly viscous OVD. For this reason, the manufacturers recommend using an OVD with a viscosity not greater than 300,000 centipoi. Though cheaper, than a femtocapsulotomy, it is still more expensive than a manual rhexis. So that's it for today. I'll see you in the next video.